first thing I'm going to start with is I'm going to put in my name, because I don't want to put the patient's name in, and then I'm going to put in, because I'm going to put in what the estimated due date is. So we select obstetrics, and then we put in the due date. So, yeah, just give me the due date. So I've got the due date. Okay. So that tells me that the gestation is 13 weeks. That's the first piece of information I need to have, because my biometric assessment is very important. I know what I have in terms of how the baby's growing. So I start off with this sweep. Thank you for turning the lights off. I start off with this sweep. So if I look down here, this is the cervical canal, and then I come up to the abdomen on a transverse sweep, and then I come up to the fundus. You see when I do this sweep that my sector width is not max, so I need to open my sector width so it is maximum, because I did not catch the edges of the uterus. So that's, I have a single baby in the uterus, and I can see that there's heart motion present. So I've got a live baby. I then do a sweep on a sagittal section coming down, and I can see when I look at the placenta, I can see the placenta is on the posterior wall, and then I come down in a sagittal section of the cervix. So this is the cervix here, and I save that image to file. So that's the first thing I do, is I confirm that I've got a live baby, and then I go to a full screen. And the next thing I'm going to do is I'm going to reduce my depth. So that's the next thing. So I do not press toggle zoom. I do not do this. I virtually never toggle zoom. Well, very seldom toggle zoom. So the next is I reduce my depth. And once I reduce my depth, I'm then just going to slightly rotate my transducer, and I'm now going to very slightly magnify. Once I've got that, I'm going to my dynamic range is at 7. I'm just going to slightly increase my dynamic range, and I need to catch the rump end of the fetus. So when you're doing that, you're taking a sagittal section, you have the nuchal fluid in view, and you have the nasal bone. And when I press calc, I go to crown rump length, and I measure from the rump end of the fetus up to the crown of the fetus, and I press enter on that. That's okay, I'll just do it again. So I press crown to rump length, and that gives me 66 millimeters, which is 13 weeks and 0 days. So this is exactly the gestation that the patient is. So that's a good start in terms of gestational age calculation. When I look at the baby in a sagittal section, I now want to, if I want to take a nuchal translucency measurement, I have to get my magnification so it meets the ISUOG guidelines. So if I look at that measurement, I'm going to slightly increase my dynamic range just to increase the contrast. I then can select my image. I just go to image select, and then for the image I can then just toggle it very, very slightly so it's occupying more than 3/4 of the screen. And then I can press calc, and I can press the nuchal translucency, and I place the transverse bar of the nuchal translucency over the skin line, and then I drop it vertically down with the transverse bar covering. So I'm just measuring the fluid, and then I press and enter. So I just measure that again. So I press there, transverse bar, just measuring the fluid, and transverse bar. And you can see that the fetus is firstly in a horizontal position. So this is important for the ISUOG guidelines. There's fluid underneath the chin, so the fetus is in a neutral position. It's a perfect mid-sagittal section because I have the nasal bone, and I have an adequate magnification. So this is an acceptable nuchal translucency measurement of 2.5 millimeters at 13 weeks gestation. And I save that measurement to the drive as a single image. I also, in this view, I have the baby in a nice position for also measuring the brain stem, and I can measure the width of the brain stem, and I can also take a measurement, but I will get better measurements, but that's the intracranial translucency, and this is the cisterna magna, so that measurement is normal. I also can draw a line from the tip of the maxilla. This is the sphenoid bone, and I draw a line over the sphenoid bone, and I then reach the occipital bone, and this here is the thalamus. and then beneath the thalamus is the mesencephalon. This is the mesencephalon here, or the cerebropeduncles, and this point here is the line that separates the mesencephalon, and it lies above the maxillo-occipital line. So seeing a normal brainstem, seeing a normal intracranial translucency, and seeing a normal maxillo-occipital line, it brings me great reassurance. I can also take a measurement from the brainstem, which is the posterior border of the brainstem, to the inner border of the occipital bone. I can also take a measurement of the nasal bone, and I can also measure the prenasal space. I can also calculate in this image here, calculate a generic angle, and I can draw an angle along the superior border of the maxilla, and then move this angle and can calculate the frontal maxillary facial angle, which is normal. So you can see from one image all the measurements that you can take with regard to normal fetal development, and I save that image to the hard drive. So I have a crown rump length, I have a nuchal translucency, and some of the other biometric assessment. I'm going to now pull back in my dynamic range, and as I'm looking, I will see that I'm looking at the hard palate. I can see the separation of this structure here, which is the vomer. So this is the vomer of the hard palate. Just to check size, go to keyboard, check size. And I'll place this over the vomer, and this here is the hard palate. So once I'm able to see that, it tells me the baby doesn't have a cleft, because I see the separation of the vomer from the hard palate. I also save that. If I go to try to get better measurements now of the midbrain and the brainstem, I think I have a better intracranial translucency measurement, so I measure from here to here. I think I also have a better brainstem measurement here, and I also have a better cisterna magna measurement here. Sometimes, when you take these measurements of the brainstem, you're not actually getting a perfect mid-sagittal section, because sometimes it's quite oblique. Say, if you look at this measurement there, I do not have a mid-sagittal profile, but I have my best midbrain measurement. That's the best one which I've obtained. So sometimes when you're taking intracranial translucency, it's in that section. When you come along to this image here, and I'm going to just zoom this image, I'll just save a cine and come back to it, but yeah, thanks very much. So if into this image, I'm going to split the image in two, and I'm going to show you that this is a very important landmark here. This here is the anterior horn of the lateral ventricle on both sides, and I'll tell you why that's important in a second, but I'm just going to do something different. I'm going to come down now and look at the retronasal triangle. So when I'm looking at the face, I look at the retronasal triangle, and I'm looking here over the bottom of the hard palate. So this whole structure here is the hard palate, and then here's my triangle leading up to this point here. That's important from the point of view of excluding the presence of a facial cleft, seeing a nice normal retronasal triangle. In this view, the reason why those measurements are important of seeing these two echogenic lines is this is how to get a perfect nuchal translucency and I'll split the image, so you see the two lines of the anterior horns, and when the baby's in that position, you then just simply rotate your transducer 90 degrees. So now I can see them, and then I rotate 90 degrees, and this is a very reproducible way of how to get a nuchal translucency measurement. So if I come back there, this is the border of the anterior horn, and this is the point here that I rotate the probe. Sometimes I use my other hand and I fix the probe so it turns 90 degrees if I'm struggling in getting a nuchal translucency measurement. In this baby, it was very easy to get a nuchal translucency measurement, but sometimes I will hold it like this, and I see the anterior horns, and once I've got that, then I simply rotate the probe to a perfect 90 degrees, and it will get me a nuchal translucency measurement. So that's just a practical point. In terms of looking at the baby's face, I'd like to produce an image showing the mandible. So I'm going to split the image, and it's going to bring into view the mandible. Now the mandible is quite an acute angle bone, and I'll tell you what I mean by this. You take a generic angle, and if you look at this angle to come to this point here, and look at the angle of it. It's really quite a tight angle. It's almost sort of 79 degrees. And that is the mandible. It's a very narrowed angle bone. Whereas the alveolar ridge, when you update and look at the alveolar ridge is a very wide bone. So if you come up to try and get the baby up, there we go. Whoops. So if I come back to that and catch it. So if I come to the alveolar ridge there, you see the alveolar ridge is a much wider angle bone, and then this is the lip covering. I'll try and get a better alveolar ridge. So I do this as an exercise from the point of view of excluding facial cleft lip. So there's the jaw, and then here's my alveolar ridge. So that's the image that I like to save to the hard drive. And the lip is not very easily seen, so I'm going to come out of Ultra HD, and I'm going to increase my acoustic output and turn up my gain just ever so slightly. And I want to actually see my upper lip. So I'm going to magnify my upper lip and just put back a little bit of my gain, because what I want to see is the lip covering all the way across, that there's no cleft lip. For me, in detecting cleft lip, the best way to do it is in this axial section. So just try one more time to get a better image to show that to you. So there's the anterior horns, and there's moving up onto the orbits. You can see the lens within freeze. You constantly use cine loop in imaging because the baby moves so much. But this shows you the lens within the eye, and there's no cataracts. So it's important to seize the opportunity of looking. I'm only measuring this to show you. I don't measure the lenses normally. But if you see the lenses there and you see the orbits, this is the best way for picking up hypotelorism. So you look at, say, a generic area. If you look at this here is the orbit on this side, and then you measure the orbit on this side. You normally should be able to fit about one orbit between the two, and that's a normal configuration. So if you're ever wondering whether there is hypotelorism or hypertelorism, just subjectively do this. You do not have to measure like I am doing now, but just in your own mind, just see that there's a normal distance between both of the orbits. When I come down onto the lip now, I'm getting a better view on that lip to see that there's no clefting, and I'm happy that that lip is intact all the way to the freeze. The baby's moving. Again, I'm using cine loop all the time. So this is the lip here, and there's no defect in the lip. You know, if sometimes you want to improve the image, you can jump to a higher frequency probe. So that's on that penetration setting. So if I come around and look at exactly the same thing, and this is with a high frequency linear probe, you see the definition that I'm getting of the choroids. It's beautiful because I'm seeing the homogeneous appearance of the choroids. I'm seeing the falx. I'm seeing the frontal bone, and now my lip. I don't know if you can appreciate that, but that lip is just very intact. There's no suggestion of any clefting across it. This is the lip going across the face. I'm just drawing these measurements just to point out to you what is the lip. So there's no clefting. So sometimes just a high frequency linear transducer can do that for you. When you're looking at the nasal bone, and you're looking at this area here, which is called the nasion, just here, and that's where you're measuring the nasal bone. The first thing you do is you increase your dynamic range, and you bring that up, and it'll just define the edges of the nasal bone from here to here, and then beyond that is the nasal cartilage. So I'm just going to go back to the 2 to 9 and just continue the assessment of the face. In terms of looking at the baby's head, I'd like to show just the landmarks and taking a 4-segment analysis. So the baby is pointing in a position where the head is anterior, and I'm going to do a 4-segment analysis, just showing starting superiorly and then working our way around. So this shows that the choroids occupy more than 50% of the lateral ventricles, and I can see that there is fluid surrounding the choroids, and this is, to me, is a very normal looking first section. So I then update this, and then if I come down a little bit lower, I will see a fluidful space that is ovoid, and I'll come back to just, let me take my aqueduct distance next. So let's see if I come around to the side. So this is the aqueduct distance, and then let's take my last measurement, which is the fourth ventricle. So the fourth ventricle is lined by this echogenic fluid. So this is my 4-segment analysis, and this shows you the choroid, and this looks like a butterfly. So if you look at the ISUOC guidelines, it makes reference to this. So this is the body of the butterfly, and then these are the wings of the butterfly. And that excludes holoprosencephaly because I can see the fat is intact and the choroids do not join anteriorly. And this structure here is the cavum velum interpositum, and this structure here is the aqueduct of Sylvius, which is a very striking structure. With regard to the aqueduct of Sylvius, we measure from the posterior border of the aqueduct of Sylvius to the inner border of the occipital bone, and at 13 weeks that should be more than 2.5 millimeters. And then this structure here, this is the choroid, which is lining the roof of the fourth ventricle. And there's a nice paper written by Valdo Sepulveda, and there's another paper subsequent to that saying if the choroid is absent, it's got a strong association with posterior fossa anomalies, spinal defects, and extra CNS malformation. And this is the intracranial translucency, which you're measuring in an axial section. So that's the analysis of the baby's brain. I know that the baby's in a nice position for the heart, so I'm going to examine the heart, and I'm actually just going to take a clip to make the point for you. I'm going to say the C2, Cindy is P1, is it? I'm just going to take a clip of the heart with P1, okay? And I'm just going to say that's what we started with, and I want to bring you back to it. So the first thing that I want to do is I want to reduce my depth, and the next thing I want to do is I want to take down my sector width, and then I want to go into an HD zoom. And when I'm in HD zoom, I'm then going to increase my dynamic range, and then I'm going to go into a sub-menu, and I'm going to change to a tint of ice. And then I'm going to come back to my main menu, and then I'm just going to pull back, and I'm going to split my image, and I've established that the stomach's on the left-hand side, and I'm just going to go for a 4-chamber view of the heart, because I want to confirm that the heart is in the 2/3 of the heart is in the left hemithorax, and that 1/3 is in the right. And if you look at it, if you draw a line up from the vertebral body up through the sternum, you can work out about 2/3 of the heart is in the left hemithorax. So I look at I do what's called SARS. So I start off with SARRS. And this stands for size, axis, rate, rhythm, and situs. That's the first thing I do in assessing the heart. So when I look at this heart, the size, axis, and the rate, rhythm, the situs are normal. So the next step I want to do is I want to look at the structure of the heart. So this is where it becomes so important in terms of me going to a setting where I'm going to look with color. So again, I HD zoom, I'm going to magnify that up, I'm going to go to radiant mid, and when I'm looking at this here is I see the movement of the AV valves, I see a left ventricular outflow tract, and then I would see to the 3-vessel view, and again I use simulate because the baby is moving. Once I've got this, I then go to, my preference is power, and once I've got a power setting, it's on 18. So I set this first, and I got on to 23. Once I've got a power setting on 23, I then just split the image, and I just do my screening examination, where I get the inflow into both right and left cardiac ventricles. And then I do a split screen just showing me my 3-vessel tracheal view. So if you look at the ISUOC basic cardiac guidelines, that tells me this baby's got a normal heart, because there was concerns about the nuchal translucency, and therefore we need to make sure that the heart is normal. So that's looking just on that, but I want to do a lot more detail than just looking at a 4-chamber and a 3-vessel tracheal view. I want to know does the rest of the anatomy of the heart is normal. So I need to optimize things. So the first thing is I want to have a higher degree of magnification, and I want to split it into 2D, 2DC, and then I want to bring my autonomic range. Can I get my autonomic range back? So in looking at a split image, what I want you to do now is to look at the septal leaflet of the tricuspid valve, and I want you to look at both AV valves that they are moving. Now, the baby has moved into a difficult position for me. Do you see that? So that's okay. I'm going to come back to the heart. So I'm now going to go back to my first trimester settings, and I'm going to continue with the anatomy and wait for the baby to turn back again to complete the heart. Once I've got the baby having turned over, well then this is the time for me to examine the kidneys because it's spine up. So I'm going to go to the kidneys, I'll go to an Ultra HD setting, come back out of that, slightly magnify the image, and now I can see that I have a kidney on the near side. So this is the kidney from top to bottom on the kidney. It can be hard to see the kidney on the far side, but I think I've got the kidney on the other side as well. Again, I use CineLoop review, and I save that image of the kidney. Once I've got both kidneys in view, I then go into a higher degree of magnification, and I zoom it right up, and then I'm going to look at the vessels supplied to the kidneys, because sometimes seeing the renal arteries can be challenging. Now my PRF is at 11, I need to reduce it further, and then I'm going to magnify the image, and then I'm going to increase my power just to bring both renal arteries into view. If I'm finding that it's hard to bring both into view, but I think I've got them there, sometimes you can split and demonstrate the artery that's on the far side in blue, and then you can demonstrate the artery that's in the near side in red. But if you are struggling seeing the vessels on each side, the next thing I would do is go to slow flow. So I come out of the kidneys, come out of colour, and the baby moves back again. It's a very active baby. I'm now just going to look, let's pretend we did not see the renal arteries. The next thing to do is after moving to power, then to move to slow flow. When I go to slow flow, I like to go into a map, and I select a colour map of 4. And then you can see that the vessels just are much easier to see with slow flow. And this is a general principle, and when I go back to examining the heart, I'll be showing you as well. But you can see you've got both renal arteries coming in, and you can see the length that demonstrates in slow flow is different to what you saw with power. And it's just that added sensitivity that slow flow brings, and it can be very helpful, particularly if the patient is of large BMI and you're struggling seeing the anatomy. The baby, just very, very quickly, is in a transverse position, and at the very beginning it was not in a transverse position. So very quickly, I just want to go back and show you those 4 segments of the brain. I'm just going to come down to the third, just there, and then come down to the aqueduct of Sylvius. I just want to say this while it's in a transverse position, and then that's the 4th ventricle. So that's the 4-segment analysis that the baby wasn't in a great position at the beginning, but anyway, just to show you that quickly. So to come back to looking at the heart, so the baby is in a little bit of a better position for coming back to look at the heart, and I want to finish interrogating the heart because I've only got the 3-vessel tracheal view. So once I'm on this view here now, I'm looking at the AV valves on both sides. I'm looking to see if there's any evidence of a ventricular septal defect. So I'm just looking around here to see if there's dropout, and I'm looking to see the movement of the mitral valve and the aortic valve. I'm going to go back to my power setting, and I'm just going to have a closer look at the left ventricular outflow tract. And as I rotate on that to get the LVOT, I'm just making sure that the aorta arises from the left ventricle and there's not any aortic override. And the fact that I'm seeing that the caliber of the aorta looks normal tells me this is a very, very likely to be aortic override. And when I go for a sweep, I can see that the aorta is crossed over by the pulmonary artery. So if I rewind that, this is the pulmonary artery, that's the pulmonary artery, and it crosses over the aorta. So it's the aorta, the pulmonary artery, it's crossed. So there's no transposition of the great arteries, and that's important for me to see that as well, because sometimes TGA can present with an increased nuchal translucency, although this is not very common. Once I get the baby back in this 4 chamber, I need to look at the pulmonary veins, and this is where I go to slow flow technology. So I want to see if there's normal pulmonary veins. So if I just freeze in that image there, I catch the pulmonary, so this is heading towards the heart. So this is the pulmonary veins coming in and draining the left atrium, and this is the pulmonary vein blue, which is going the correct direction for us to be seeing pulmonary veins entering into the left atrium. So I say that as a cine loop. Once I've got that, I then look at the interventricular septum with slow flow, because sometimes this can be a very nice way for me to see ventricular septal defects. When I do a cine loop rewind, I see this is the branch of pulmonary artery, so this is the right pulmonary artery, and this is the aorta. So I see the right pulmonary artery, the arterial duct, not the aorta, the arterial duct. This is the arterial duct, and then I see that this is the aorta. So when I look at the branch pulmonary arteries and I look at the aorta, I can see the sizes of these vessels is for what they should be. I then look at the 3-vessel tracheal view, and on the 3-vessel tracheal view, I can see the azygous vein. So if I come back and just rewind that. So this is the SVC coming into the uterus here, and then draining into the SVC. I have the azygous vein, which is just coming in here. And then here is your trachea, and then this is your transverse aortic arch, and this here is your main pulmonary artery, coming out the right ventricle, and this is the arterial duct. So if I look at the anatomy of all those structures, I'll just come out and just bring my box down and just magnify that up. So if you magnify that up, you can see nicely now the branch pulmonary artery, 3-vessel tracheal view, and now I can see it come up a little bit higher, and I increase my gain, I can catch the internal thoracic arteries and the subclavian arteries. So if I just do the internal thoracics first, I'm going to catch here this is the left brachiocephalic vein coming in here, and this is the internal thoracic artery and vein just coming in here. And the internal thoracic artery and vein on both sides appear normal. So, and in between the internal thoracic artery and vein and the sternum, which is up here, it forms the box. So this is the box of the thymic box. So if I was worried about this baby having thymic hyperplasia related to 22q deletion, this would not support that diagnosis. So I see a nice thymic box. Remember, I've saved this as a cine because I wanted to go back and have a look at it, and just press cine, and I want to rewind it because I also have a subclavian artery and vein coming in here. So if you look at it coming in here, the artery is posterior and the vein is anterior. I might just go for an update on it, and I catch the subclavian artery and vein on both sides. So if you look at that, you can see the subclavian artery and vein. If I slightly increase the gain on the subclavian artery and vein, you can see the internal thoracic artery coming off the subclavian artery, and then you can see the subclavian artery going out. You want to work out that this is the left side of the heart, therefore this is the left subclavian artery and the left subclavian vein, and the one that you're more interested in is the right subclavian artery. So if you look here, this is the right subclavian artery here, and if you look at the level in which the subclavian arteries come off, they come off approximately halfway across the chest. So this is the posterior vertebral body here, this is the sternum, and you're seeing that the subclavian arteries are coming off halfway, whereas if it's an aberrant subclavian, it will start in a very posterior position and go out. So I save that image to file, and I look at the subclavian arteries. I can see the left brachiocephalic vein is not dilated. If you look at the subclavian artery on the far side, you can see the branches of the subclavian artery, and this is the costovertebral branch. I can't remember the name of this one, but there's 3 posterior branches that come off the subclavian artery. Now you must remember this baby is 13 weeks of gestation, and you're getting the detail where you're seeing the branches coming off the subclavian artery. It just tells you the power of this technology. So I'm going to come back. I'm not interested in subclavians anymore. I just want to now focus my attention on the 3-vessel tracheal view. So on this one here, I magnify it up, and I see the main pulmonary artery and the aorta, and I see the caliber of these vessels, so it's normal. And then I'm going to look at the outflow tract. So this is the left ventricular outflow tract. Oh, yeah. Oh, see, okay. I do not. Okay, so this is the left ventricular outflow tract. We have one more patient. I think we're just going to jump to that. So anyway, the other things I wanted to show you, and maybe we'll show you in the next patient depending on the position, but I want you to look at the atrial appendages. So you're coming down either side, you see the atrial appendages, they're still quite a size. So this here is the left ventricle, the left atrial appendage, the right atrial appendage, which you can see extend right down the full length of the heart. You can see the branch pulmonary arteries, the branch pulmonary veins, the interventricular septum, and then you can follow down the intrahepatic venous anatomy. I better stop there.